Hello everyone, this is Stacia. We're going to talk about Chapter 21, Promoting Safety. Here's your concept of safety and the objectives for your review. So safety is a basic human need, second only to survival, such as, the needs such as oxygen, nutrition, and fluids. As a nurse, you will be fundamentally concerned with the safety of your clients. You must also be concerned with your own safety and the safety of other care providers around you. Many accidental injuries can be prevented by being aware of hazards and taking reasonable precautions. According to the CDC, accidents or unintentional injuries are the third leading cause of death in the U.S. An estimated 175,000 people die each year as a result of accidents. Expressed another way, one person dies from one accident every 5 minutes. Poisoning is now listed as the #1 cause of unintentional death, followed by motor vehicle accidents, falls, accidental hanging, strangulation or suffocations, and drowning. This doesn't count the numbers of people who received injuries that disabled them beyond the date of injury. When we look across the lifespan, infants and toddlers, drowning is the leading cause of death for children ages 1 to 4, followed by motor vehicle accidents, falls, choking, sudden infant death syndrome or SIDS, and ingesting poisons or other critical safety concerns. Infants and toddlers are completely dependent on others for their care. They have the ability to walk and manipulate objects before they have the judgment to recognize dangers such as falling. In addition, infants and toddlers are curious and tend to explore the environment by putting objects in their mouth. This is why the incidence of choking is highest between 6 months and 3 years of age. As mobility continues to improve, toddlers gain more freedom, and their curiosity leads them to explore cupboards, stairs, open windows, swimming pools, and other hazards. The preschooler, they're high that motor vehicle accidents continue to be a major cause of accidental death, along with drowning, fires, and poisoning. However, falls are the primary cause of non-fatal injuries. After age 3, children are a little less prone to falls because their gross fine motor skills, coordination, and balance have improved. However, the extension of play to the outside environment, like playgrounds, pools, front yards, and so on, create additional safety concerns. Your school-age children, motor vehicle accidents continue to be the leading cause of accidental death in children in this age group. However, the leading cause of non-fatal injury is falls. School-age children have developed more refined muscle coordination and control, and their decision-making skills have improved. However, because they become more involved in the activities outside the home, bone and muscle injuries are common. Injuries are often related to sports, skateboarding, or bicycle riding. Playground injuries are also common. Most school-age children are ready to try any new skill with or without practice or training. They are less fearful than toddlers. Exposure to the wider school neighborhood environment also increases the risk for injury inflicted by people outside the home, like an abduction. Adolescents, the leading cause of death in this age group is motor vehicle accidents, and these are frequently associated with drug and alcohol use, followed by suicide. Sports and recreational injuries, including diving and drowning accidents, are also common, especially when drinking and drug use are involved. Peak physical, sensory, and psychomotor abilities give teenagers a feeling of strength and confidence, yet they lack the wisdom and judgment of adults. This combination, along with feelings of being indestructible, makes them more likely to participate in risk-taking behaviors, and in turn makes them more prone to injury. For adults, unintentional poisoning is now the major cause of death and injury in this age group, followed by self-harm or suicide causes more death than motor vehicle accidents. Workplace injury may also be a significant concern. Other injuries to adults are related to lifestyle, like excessive alcohol use, stress, carelessness, abuse, and decline in strength and stamina. For many, work and family responsibilities often leave little time for regular physical activity, increasing the risk of musculoskeletal injury in the weekend athlete. Older adults, although many older adults have intact senses that enable them to continue to enjoy life as they age, physiological changes do occur. These changes may include reduced muscle strength and joint mobility, slowing of reflexes, decreased ability to respond to multiple stimuli, and sensory losses, particularly hearing and vision. These changes increase the older adult's risk for falls, burns, car accidents, and other injury. Falls are the most common cause of accidental death for adults age 50 and older, per the CDC. In your F.A. Davis book, you can see Table 21-2 on page 547 for more information on this. In addition to developmental stage, individual factors also influence a person's risk for unintentional injury, like their lifestyle, smoking, alcohol use, not wearing seatbelts, etc. Cognitive awareness, confusion, and or loss of short-term memory due to stress. Sensory perceptional status, loss of hearing or sight, so loss of first-line defenses. Ability to communicate, language or hearing barriers, mobility status, mobility, balance, and endurance issues, physical and emotional health, depression, feelings of hopelessness, awareness of safety measures. Kids and older adults have reduced cognitive awareness. Most poisoning of young children occurs because of improper storage of household chemicals, medicines, and vitamins, and cosmetics. Lead paint, banned in 1978, may still be around in homes. Never leave kids unattended around meds, cleaning solutions, or poisons, etc. Older children and adolescents may attempt suicide by overdosing with medications or may be poisoned accidentally when experimenting with recreational or prescription drugs intended for adults. In adults, most poisonings occur as a result of illegal drug use or misuse, abuse of prescription drugs, especially narcotic medications, tranquilizers, and antidepressants. Treatment choice depends on the poison ingested. For most poisonings, the most effective intervention is professional administration of activated charcoal orally or via gastric tube. However, charcoal is not effective for ethanol, alkali, iron, boric acid, lithium, methanol, or cyanide. Depending on the situation, other options for medical treatment include gastric lavage, such as pumping one's stomach, dialysis, administration of antidotes, and forced diuresis. Never induce vomiting when the ingested material is acidic or caustic to the esophagus. Carbon monoxide, or CO, is a colorless, tasteless, odorless, toxic gas. Most CO poisoning occurs at home. Exposure can cause headaches, weakness, nausea, and vomiting. Prolonged exposure leads to seizures, dysrhythmias, unconsciousness, brain damage, and death. The burning of fuel, such as wood, oil, gasoline, natural gas, kerosene, and coal, produces carbon monoxide. Dangerous levels of CO can build up because of a faulty furnace, and it builds up quickly in an unventilated garage where the car is running. Other consumer products involved in CO-related deaths include lawnmowers, charcoal grills, gas water heaters, camp stoves or lanterns, and gas ranges or ovens. Many CO deaths occur during cold weather among older adults and the poor who seek non-conventional heat sources such as gas ranges and ovens to stay warm. CO occurs at the scenes of fire and are fairly common in suicides. Scalds and burns from hot water, steam, or grease. They're the most common cause of burns in children younger than the age of 3. Warming food or formula in the microwave may cause the food to become hotter than intended, leading to burns in infants and young children. Sunburn can cause a first or second degree burn, and burns may occur from contact with metal surfaces and vinyl seats when cars are parked in the sun. Scalding burns, especially on both feet or both hands, and cigarette burns in children and vulnerable older adults should always prompt you to assess for abuse. Chemical agents such as acid, alkali, and other organic compounds can also cause localized burns. Home fires are a major cause of death and injury. Older adults and children younger than the age of 5 years have the greatest risk of fire death. Cooking fires are the #1 cause of home fires and home fire injuries. However, most fatal home fires occur while people are asleep. Here's an interesting fact. People back in the day, they would sleep in 2 cycles. Like they would sleep from, when the sun went down and maybe wake up at around 11 p.m., get up and do some other chores around the yard or around the home because they were worried about robbery and also worried about fires. So that's how they survived their nights. And then most fire-related deaths occur from smoke inhalation. Home oxygen equipment, kids playing with matches, improper use of candles, and faulty wiring. Falls are the 3rd leading cause of death in 65-year-olds and doubles when they're 75 or older. More than half of the falls occur at home. Environmental factors that contribute to falls include slippery floors and bathtubs, lack of grab bars, low toilet seats, high beds. Health issues that increase the risk for falls include poor vision, hypotension or low blood pressure, a history of falls, dizziness, pain, alcohol use, cognitive impairment, polypharmacy. That's just when you're on a bunch of medications, arthritis, gait or balance deficits, age greater than 65 or greater puts all these people at risk for falls. Gun ownership is a controversial issue. Some people keep guns in the home for protection and or recreation, hunting, target shooting. However, guns are a source of unintentional injury and death. Gun safety and security are especially important when there are children in the home or someone with a substance abuse problem. Young children may handle a loaded gun with tragic results. Household access to firearms has been implicated as a risk factor for youth suicide and domestic homicide, as well as unintentional injury. Substance abuse problems and mental illness with impulsivity is a dangerous combination with guns in the home. Because of the frequency and severity of unintentional firearm injuries involving children, the American Academy of Pediatrics and other groups have mounted efforts to educate parents about firearm safety. Suffocation by smothering is the leading cause of death for infants younger than 1 year old. Suffocation may be caused by drowning, choking, or a foreign object, or inhaling gas or smoke. And if any of you have small children, maybe you've had experiences with this where I did with my youngest daughter. Actually, both my daughters, one choked on gum, one had some candy, and it's a very terrifying moment when you're so afraid of, what could happen. After that, my kid was lucky I didn't chew her food up and put it in her mouth like a baby bird after that, right? You cut it up teeny tiny pieces. Food items, including hot dogs, raw vegetables, popcorn, hard candies, nuts, and grapes, are responsible for most non-fatal choking accidents. Non-food items, such as latex balloons and plastic bags, cause a majority of suffocation deaths in young children. Suffocation of infants is often related to bed or crib hazards, such as excess bedding or pillows or toys hung from long ribbons inside the infant's crib. Infants can become entangled in cords from window blinds or in the ribbon or string used to hang a pacifier around the infant's neck. High risk for drowning affect the 1 to 18-year-olds, and kids up to 4 are especially at risk. Take-home toxins. These are hazardous substances transported from the workplace to the home. The National Institute for Occupational Safety and Health reports that pathogenic microorganisms, asbestos, lead, mercury, arsenic, pesticides, caustic farm products, and dozens of other agents cause significant morbidity and mortality in workers' homes. These toxins are most likely transported to workers' homes on the workers themselves, on their clothing, or on objects brought from the workplace. In the home, contamination occurs via any of these three sources. The arthropod vectors, such as ticks that are responsible for Lyme disease, dust particles that are inhaled, like anthrax spores, arsenic in mice, and smelter dust, and direct skin-to-skin contact or direct contact with contaminated clothing. Okay, testing your knowledge. Which of the following instructions is most important for the nurse to include when teaching a mother of a 3-year-old about protecting her child against accidental poisoning? A, store meds in a cabinet out of reach for the child. B, purchase meds in child-resistant containers. C, take medications in front of the child and explain that they are only for adults. Or D, never leave a child unattended around medications or cleaning solutions. What do you think? The answer is D. A child should never be left unattended around medication or cleaning solutions. Answer D is the answer that would prevent an accidental poisoning. Make sure you pay attention to your NCLEX style questions, because they might say, what is your priority? What is the most important? Things like that, because all answers could be right. Here's another testing your knowledge. A child has had hiccups for 2 hours. Is this a sign of suspected ingestion of poison? What do you think? Nope. Hiccups are not a sign of suspected ingestion of a poison. So safety hazards in the community. Motor vehicle injuries are the second leading cause of accidental death in the U.S. Adults and children older than 1 year of age. Teens and young adults 16 to 24 are more likely to be distracted by devices, resulting in more MVAs in this age group. Failure to use seatbelts and proper child care seats continues to be the major contributing factor. Severe injuries and death also occur from airbag deployment when young children are improperly placed in the front passenger seat. Many of the fatal motor vehicle accidents during adolescence involve abuse of alcohol or other substances. Driver distraction from talking and texting with cell phones is a contributor to MVAs for adolescents and adults. The risk of being injured or killed in a car crash increases for older drivers. Every day, on average, 500 people over the age of 65 are injured in an automobile accident. So community-acquired pathogens, foodborne pathogens, food poisoning, non-specific term that describes illness caused by injecting bacteria and other microorganisms or their toxins in food. Improper food storage and preparation are a major cause of food poisoning. Raw foods are commonly associated with foodborne illness, for example, raw meat, poultry, eggs, shellfish, raw fruits and vegetables, and unpasteurized milk and fruit juice. Poisonous chemicals in the environment, such as mercury, arsenic, zinc, and potassium chlorate, may also contaminate foods. Education is an important intervention for preventing food poisoning. Vector-borne pathogens, organisms that transmit pathogenic bacteria, viruses, and protozoa from one host to another. This includes mosquitoes and other insects, ticks, sandflies, lice, cockroaches, rodents, birds, and other animals. Waterborne pathogens, people who live in substandard housing may not have safe drinking water, hot water, or washing, or adequate methods of waste disposal. People in the rural areas often depend on private wells, which may not be adequately maintained and tested for pathogens, such as Giardia lamblia, that's a parasitic infection that causes GI symptoms, such as marks, stomach cramps, bloating, nausea, and bouts of watery diarrhea. Or Cryptosporum, which is a microscopic parasite that causes watery diarrhea. It lives in water, food, and soil, or on surfaces that have been contaminated with infected poop. So says the CDC. And E. coli, a group of bacteria that can cause infections in your GI tract, urinary tract, and other parts of the body. So pollution, motor vehicle emissions are a major cause of outdoor air pollution in the U.S. Other toxic pollutants are asbestos, toluene, metals such as mercury, chromium, and lead compounds, other emissions from factories and power plants. Indoor pollutants include radon, carbon monoxide, allergens from dust mites, cockroaches, mold, rodents, and pets. Allergens are an important health issue because people spend most of their time indoors. Passive exposure to tobacco smoke is associated with respiratory disease and cancer. Environmental air pollution is linked to cardiovascular disease and respiratory viral infections. Water contamination, such as lakes, rivers, and streams, ultimately affects both recreation and food production of these waters. Pollution occurs when inadequately treated or inappropriate quantities of human, industrial, or agricultural waste are released into the water systems. If the pollution is severe enough, the water may become unsafe for human consumption. Noise pollution, substantial exposure to noise has been associated with a range of adverse health effects, including hearing loss, stress, elevated blood pressure, and loss of sleep. Noise is pervasive in our society. For example, road traffic, jet planes, garbage trucks, construction equipment, lawnmowers, and loud music. People who live or work near major roads like bus depots, airports, and trucking routes are at greater risk, as are those in certain work environments. Soil contamination can be caused by improper waste disposal and excessive use of pesticides. Agricultural, industrial, and manufactural processes create solid and toxic waste. Animal, radioactive, and medical waste pose special problems. Weather conditions play a major role in outdoor recreation programming. It is important for professionals, participants, and outdoor recreation providers to understand severe weather conditions and the dangers associated with them. Suggest that patients have a weather radio receiver unit with a warning alarm tone and battery backup to receive warning bulletins. Check the weather forecast before leaving for extended periods outdoors. Watch for signs of approaching storms. If severe weather threatens, check on people who are elderly, very young, or physically or mentally disabled. Don't forget about pets and your farm animals. So safety hazards in the healthcare facility, we have what we call never events. They're also known as serious reportable events, or SREs, are healthcare acquired complications that can cause serious injury or death to a patient, and two, should never happen in a hospital. The list of never events has been expanded over time to mean events that are clearly identifiable and measurable, serious, and usually prevented. Root cause analysis tries to solve problems by identifying or correcting the underlying causes of events, as opposed to simply addressing their symptoms. The goal is to decrease the likelihood that the problem will recur. A root cause is typically a finding related not to individual error, but to a process or system that has a potential for redesign to reduce risk. A root cause finding is usually used for the purpose of redesigning a process or system rather than preventing an individual error. RCA provides an organized structure for analysis of errors and is designed to answer three basic questions. 1, what happened? 2, why did it happen? And 3, what can be done to prevent it from happening again? Nursing has a culture of safety. It's a positive nursing unit culture, helps improve patient outcomes. Culture is a way of thinking, behaving, or working in a place or organization. The key point: in a culture of safety, nurses practice in an environment where all staff work together to create a safe unit, disclose errors without fear. That could also be called a culture of justice. Disclose errors without fear and address any safety concerns. Key components of a culture of safety include team empowerment. Every individual has the opportunity to be heard, feel important, and be a valued team member for the contribution offered. Communication. Open and honest lines of communications are needed between the team members and from the team to the other hospital units. Transparency. Team members are united in their efforts to eliminate rumors and operate with only the facts, contributing to mutual team goals. Accountability. Staff claim ownership for human error and are willing to disclose the error and help prevent similar errors. That's why we call it some about being able to talk about medication errors openly. We call that a culture of justice. That's what we want. But which you'll learn more about this in your pharmacology class, that sometimes it's not just, oh, I made a mistake, let's do a root cause analysis and try to fix the problem, because it could have been the symptom. What they're doing is put nurses in jail. So I'm sure that you've seen different news reports about terrible tragedies that have happened, and nurses ending up in jail for it. So your opinion on it could be go either way, of course, but you'll learn more of that in your pharmacology class. And then also, high reliability organization, or HRO, is a commitment to patient safety and quality healthcare, and it's based on maintaining high organizational standards. As you see on this slide, caring is creating a culture of safety. It's a basic need for everybody, and your commitment to safety is one way for you to show that you care. As the person closest to and most constantly with the patient, you can facilitate a culture of safety. By speaking up for safety, use cuss words, C-U-S. C, state your concern. U, say why you're uncomfortable. S, state this is a safety issue. Explain how and why. Stopping the line or calling a pre-procedure timeout. That's what they do in surgery, so that everybody can know, who's the person, what are they here for, where are we working on, the right or the left or whatever. And of course, any new rules that have been instituted, because errors had occurred in surgery, where you've heard, way back in the day, or maybe not way back, but, maybe they amputated the wrong leg during a surgery because communication wasn't good. And then some places, some doctors, when I had knee surgery, I had to mark my own leg. And, different people do it. You can see some funny things where people like draw a picture or just do whatever they do when they're marking their leg. I'll let you read the rest of this slide, but this is how we try to create a culture of safety on the units where we work. So we should try to do that at all times. So, if a standard of practice is breached or an unusual incident occurs, like a visitor or patient falls or is injured, you should complete an incident report, also called a variance report or occurrence report. These reports are used in part for quality improvement in the agency and should not be used to discipline staff members or be placed in employees' files. The goal is to prevent the incident from occurring again by formulating corrective measures. In many states, an incident report is not made available as a part of discovery and litigation. It becomes discoverable, available to the plaintiff, if it is mentioned in the medical record. So the key point is you can prevent an otherwise confidential report from becoming evidence by not writing incident report completed in the patient's medical record. So usually for incident reports, there's a different area in the chart for you to put these particular reports, and then of course somebody, whoever's in charge of that, will go in and do the root cause and put interventions in place and collaborate with people and try to figure out what the problem was to make it better. When reporting an incident, be sure to clearly identify the patient, date, time, and location. Briefly describe the incident in factual terms. Use the exact words of the patient or persons involved and put the information in quotes. Do not speculate, draw conclusions, or place blame. Identify any witness to the event or equipment involved. So falls are, by far, the most common incident reported in the hospital and long-term care facilities. Most important thing to do is identify risk factors for the patient falling and which patients are at risk for falling. If you identify those who are at risk, interventions can be put into place in an attempt to at least prevent serious injuries. So, where I worked, or in the hospital, wherever anybody works, they get a new admission and they're going to look at their history, they're going to do their assessment, they're going to figure out all, John here, he's 65, he has some short-term memory problems, looks like he keeps trying to get out of bed, things like that. So then we can put interventions in place which may not actually prevent the actual fall, but it could prevent significant injuries that could occur because of a fall. So you kind of gotta, the best thing to do is always assess for the risk of it, so you can put, be proactive and put interventions in place before something terrible happens. So risk factors include poor vision, cognitive impairment, difficulty in walking balance, hypotension, weakness and dizziness from disease or therapy, drowsiness from medications. Many cases involve falling from a bed, and falls occur more frequently on nights, weekends, and holidays. Why do you think that is? Probably because there's less staff, right? Most agencies have established procedures and safety features to prevent falls. Alarm fatigue, failure to recognize and respond to actionable clinical alarms in a timely manner, is the second highest ranked patient safety risk. Missed alarms cause harm most commonly when the medical device does not detect the alarm condition, the alarm is not communicated to a medical practitioner, or it is communicated but not adequately addressed. Equipment-related accidents usually occur when equipment malfunctions or is used improperly. For example, when bed alarms fail to work or are set incorrectly, when suction devices and infusion pumps are not working properly, oxygen cylinders are transported incorrectly, or wheelchairs and beds are not locked during transfers and activities. Fires, electrical hazards. Fire in a healthcare agency is more often related to anesthesia or improperly grounded or malfunctioning electrical equipment. Most healthcare agencies have policies for preventing electrical hazards. Nevertheless, patients and visitors do break the rules, so smoking cannot be discounted as a hazard. Restraints, devices or methods used for the purpose of restricting a patient's freedom of movement or access to his body with or without his permission. The most obvious form of restraint is the use of physical force by another person. A restraint may also be a mechanical device, material, or equipment such as a cloth vest or side rails. A chemical restraint given to control disruptive behavior, for example, sedatives and antipsychotic drugs. Never restrain patients for convenience. Mercury poisoning. It's a heavy, odorless, silver-white liquid metal. It is toxic in both acute and chronic exposure. It can be inhaled, ingested, or absorbed through the skin. It accumulates in muscle tissue and can cause renal and neurological disorders, especially in fetuses and neonates. Products containing mercury include thermometers, thermostats, batteries, fluorescent light bulbs, blood pressure devices, and electrical equipment and switches. Here are some different types of restraints that are used. Wrist restraints are often used in the hospital, sometimes the ICU and things like that, if we're worried a patient might pull out their tube or something like that. You'll be working with these in the lab, so some of you may have already worked with some in your job, so that's kind of what they look like. Quick release knots are used for your restraints, and remember that we don't ever tie the restraint to something that's movable on the bed. You wouldn't attach it to the side rail or anything like that. You would tie it to the bed frame because the bed frame doesn't move. And if you look in volume 2 on page 334, that will review all types of restraints in your F.A. Davis book. Some other things that you need to know about restraints that you would want to remember. So agency policy, professional guidelines, and state laws should guide the use of restraints. So everywhere you work will have their own policy regarding this. Use restraints only for safety to ensure the immediate physical safety of the patients or others. You must obtain a medical prescription from a physician or other licensed care provider. No standing orders or as needed orders for physical restraints are allowed. The doctor must be contacted if you're going to put on a restraint. You must renew restraint prescriptions every 24 hours, more often for behavioral restraints. You must modify the plan of care to reflect the application of restraints and the plan for monitoring. Explain the need for the restraint, if you must use them. Obtain consent from the patient or family when feasible. Medications are considered a restraint when they are used to restrict the patient's freedom and movement or to manage behavior. Physical holding of a patient is not always considered a restraint. Sometimes it is necessary to use devices or methods that involve the physical holding of a patient for routine physical exams or tests. Monitor and reassess. These are critical components of caring for patients in physical restraints. Assess restraints every 30 minutes more frequently for patients with behavioral restraints who may need continuous monitoring. Remove restraints for assessment, feeding, toileting, and skin every 2 hours. Patients in medical surgical restraints should be evaluated by an RN at least every 2 hours. Those in behavioral restraints require more frequent monitoring. Always use the least restrictive restraint that ensures safety and remove the restraint as soon as possible. You would go to using a restraint as the last resort. So if you've tried everything else, you've tried to calm the patient down, you've tried to reduce stimuli in the environment, you might have even tried a low dose medication, you've done all these things, but the patient is uncontrollable and he's putting himself or others in danger, then you would contact a physician and talk about a restraint. So testing your knowledge again, when implementing the use of restraints on a hospitalized client, the nurse should A, restrain all confused clients so that they do not sustain a fall injury. B, tie the restraint to the bottom of the side rail so the client cannot reach it. C, ensure that the primary care provider renews the order for restraints once every 24 hours. Or D, release the restraint and provide skin care at least once every shift. What do you think? The answer is C. This statement meets the most current guidelines for the provider's order related to the use of restraints. So the American Nurses Association, or the ANA, reports that 52% of nurses report chronic back pain, likely because many nursing tasks require bending and twisting of the torso, activities that can cause injury when the nurse does not use correct body mechanics. You're going to be starting a long career in nursing, so take care of your back. Among the most stressful activities are transferring patients, like from the toilet to the chair, weighing patients, lifting a patient in the bed, repositioning patients in bed or chairs, and changing bed linens. The ANA states that manual patient handling should be used only in exceptional situations when it cannot be avoided. For those situations, you can reduce your risk to some degree by using appropriate body mechanics. Needle stick injuries. Healthcare workers, mostly nurses and housekeeping staff, suffer up to 1 million injuries per year from needles and other sharps, putting them at risk for infectious diseases such as hepatitis B and AIDS. Since 1982, OSHA has required employers to provide engineering controls such as safer medical devices and needleless systems. Radiation injury. Radiation, this is the process of emitting radiant energy in the form of waves or particles. Ionizing radiation is used in computerized tomography, which is CT scans, and diagnostic radiology, linear accelerators in radiotherapy, and position emission tomography, which is a PET scan in nuclear medicine. Patients are deliberately exposed to radiation during diagnostic tests and certain medical treatments. Healthcare workers who care for these patients are unavoidably exposed to small doses of radiation. Violence. Hospital security may not be sufficient to protect you from injury if violence breaks out among patients, visitors, and/or the staff. This is especially true in the emergency department, which has 24-hour accessibility and may sometimes be crowded and chaotic. Under the stress of an acute illness, patients and family members alike may become more anxious and angry and act out in ways that are unpredictable and atypical for them. Testing your knowledge again. How would you as a nurse support a culture of safety? Select all that apply. A, complete incident reports when appropriate. B, complete incident reports for a near miss. C, communicate product concerns to an immediate supervisor. And D, identify the person responsible for the incident. All of those answers are correct. Good job. So the nursing outcomes classification, or NOC, standardized outcomes, depends on the nursing diagnosis you choose. So planning interventions and putting them in place. General interventions related to safety. Specific nursing activities are designed to monitor and manipulate the physical environment to promote safety. The following general activities provide an overview of your role in safe, effective nursing care: thinking, doing, and caring in all types of settings and circumstances. You assess and continually monitor the safety needs of patients based on their level of physical and cognitive function and past history of behavior. You provide client education to foster informed decisions, promote involvement in care, and facilitate post-discharge health. Evaluate and use techniques, processes to avoid medical nursing errors in the delivery of client care. Remove hazards from the environment or modify the environment to minimize hazards and risk. Use technology to deliver effective, safe care. Establish mutual goals with clients and teach clients about specific safety measures. If an accident or injury occurs in the healthcare setting, file an incident report according to agency policy. Urge patients to be active members of the healthcare team. As you see on this slide, these are all the home safety interventions you would do as a nurse or educate the family on to prevent, whatever poisoning or carbon monoxide poisoning, preventing home fires, etc. I'll let you review that. In addition to teaching home safety to clients, you should also prompt safety self-care related to particular hazards in the community environment, like motor vehicle safety. You could find that on page 567. Don't drink and drive, hands-free, use car seats appropriately. Food safety, they call those the 4 C's of food safety: clean, cook, combat cross-contamination, and chill. See self-care box, page 569. Fighting vector-borne pathogens, page 568 and 569. So mosquito prevention and rodent control. Reducing pollution, page 570, such as air, noise, and hazardous. Weather hazard safety measures, page 570, you could see that. And the family should always have a safety disaster plan. Here are a few things that will help you with some of these, help you with promoting safety in some of these areas. If you look in your chapter, page 558 to 560, I would go read that. That's important things for you to know regarding falls. The Joint Commission has something to say about reducing electrical hazards. You'll see that on page 571. Responding to fires, page 571, you have race, rescue, activate, confine the fire, extinguish the fire. Preventing the need for restraints, page 571, we talked about this already. You want to use the least restrictive device first. So use it as a last resort. There's other things that you can do first. You could review their meds, help them with their anxiety, orient them if they're confused. You could have a one-on-one sitter if possible, improve communication, modify the environment, or hourly rounding or 15-minute rounding or whatever the policy of your facility is. Responding to mercury spills, to be honest, that's in your chapter. You can read through that. I don't even know if that's a thing anymore. So I've never been privy to a mercury spill or been a part of it. Keeping equipment safe, learn how to use it safely, tag it if it's not working right. Equipment from home must be inspected according to policy as well. You can't just have them bringing in all kinds of electrical devices from home and not having somebody check that out, like maintenance or whoever. Reducing alarm fatigue. I mean, if you have absolutely everybody on an alarm somewhere, I imagine it would be easy where they're just going off and, people just kind of, their brains just kind of go off to it. So really alarms are a good thing. I think alarms are helpful to help prevent falls, not in every situation, but if you have everybody on alarms, so I think most places try to not, especially long-term care facilities, they try not to put absolutely everybody on one because then alarm fatigue could happen, of course. And then coping with violence, protect yourself before an issue does occur. So you just got to always, be smart when you're with patients. My daughter works in healthcare and she's young, and, she gets into a room sometimes and you get some family members that aren't very nice, or, they're more flirty than you prefer they be and things like this. And you don't ever want to don't ever get into somewhere where that any family member can get between you and the door. You have to consider your safety. Your safety is just as important as anybody else's, 100%. So keep that in mind. So as far as delegation goes, so remember with delegation, you can never delegate up, right? So you as an LPN can't delegate to an RN, just like an RN can't delegate to a doctor. But an RN can delegate to an LPN and also to a UAP or a nursing assistant, same as you. You can delegate to a UAP or a nursing assistant as well. Restraints. One safety activity you might delegate is applying restraints. You must first be sure that the nursing assistant personnel, or the NAP, is competent to perform the skill. So they got to know what they're doing. You can't just give it to someone that maybe has, if they say to you, oh my gosh, I've never done that before, that would probably not be the best time to say, well, go figure it out, right? You want probably use that as a teaching moment. Although you may delegate the application of the restraints, you may not delegate the assessment of the patient's status nor the evaluation of the response from the patient to the restraint. You have to do that. You may assign the nursing assistant to remove and reapply restraints to provide skin care, allow for supervised movement, to eat or whatever, and observe skin for excoriation under or around the restraint location and report it to you. Other measures. You should be sure assistive personnel are aware of and follow all safety measures and institutional procedures. Remember, we only delegate simple tasks within our assistant's scope. Give them the most stable patients. And when RNs delegate to you as an LPN, they're supposed to delegate to you the most stable patients, right? And they can't delegate their assessments and things. So you'll learn more about delegation as the, program goes on.